So hi everyone from around the country and welcome to today's seminar. Firstly, I'd like to take a moment to acknowledge the traditional owners and their custodianship of the lands on which we meet today. I pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to country. We recognize their valuable contributions to Australia and the global society. And just to introduce myself, I am a research fellow at LCC Sydney Node. I am the joint seminar coordinator together with Reddy Lee. So I would like to introduce our speaker today. So Chris.
I go by Chris, it's just easier.
Okay. Is assistant professor of economics at Emory University, who is also affiliated with NBR, CECIFO, and IZA. He got his undergrad degree from Warsaw School of Economics in Poland and his PhD from Uppsala University in Sweden. His research is primarily on child development, including its health and educational aspects, especially when it comes to the long-term and intergenerational consequences. He published in journals such as American Economic Review, American Economic Journal, Applied Economics, Journal of Labor Economics, and the Journal of Human Resources, and his research has been covered by media outlets such as New York Times, Washington Post, and probably the most fun outlet is the Onion. So let's introduce Chris. Thank you.
All right, thanks so much. It's great to be here. I too acknowledge that traditional owners and their custodianship of the lands on which we meet today, and pay my respects to their ancestors and their descendants. And it's great to be back in Australia, you know, after a few years of pandemic. I always enjoyed my time here, and this time is no different. So thank you for all the hospitality that we received so far in various places in Australia, and thank you to all of you guys for tuning in for today's seminar. If there is any internet issues, you know, blame UNSW where I am now. But other than that, if you have any clarifying questions, please interrupt me. And I was told that the general discussion should follow after the presentation. So I'll try to be brief and keep it, you know, within 30-35 minutes, and then we can have a chat. So what I'm going to present today is work with Aline Budikofer from Norwegian School of Economics and Ingrid Semp from University of Oslo, who's going to be on the market next year, so you should watch out for her because she's awesome. And it's about getting a second chance. And what we mean by this is basically exploring whether prenatal health shocks can be offset by subsequent positive inputs into infant health. Okay. And so why do we care about these issues? So I think we now have a quite robust evidence on the fact that what happens to people very early on in their lives, even when they're you know, few cells large prenatally, could have very important long-run consequences, be it when it comes to education or their health. And these kind of issues were first explored by doctors. It's the famous Barker hypothesis, and then you know, economists and other folks jumped on this and showed that that various shocks could have long-lasting consequences, including viral infections, which is going to be important for this talk. Okay. At the same time, the other strand of the literature, more so in economics and healthcare management, talks about all these kind of positive inputs that we get from things like, good neonatal care, good prenatal care, postnatal interventions such as NICU or medical screenings, or innovation, right? We discover drugs, we discover new treatment. And there is quite a lot of work also on the consequences of that. Now, what we really don't know much is how these policies or these events interact. And basically, is it the case that, if you intervene later on with a positive intervention, it could offset the initial negative shocks, or will it exacerbate it? And to go back to the economic lingo for a second, what we mean by this as economists is basically whether the two inputs are complements or substitutes, right? If they are substitutes, this means that if bad things happen to you early on, subsequent positive interventions can offset this negative effect. If the two inputs are complements, well, now we're more in trouble, because what this tells you is that the initial differences generated by a negative shock are going to be actually exacerbated by subsequent positive inputs. Okay, so this is also super important from policy perspective to actually understand in which world are we? Are we in the world of complements, or are we in the world of substitutes? Okay, so this is really what this paper is about. We're going to ask whether positive health inputs later in childhood compensate or reinforce the initial health deficiency. We're going to ask whether these interactions matter differentially, whether you think about health, because these are health shocks that we're going to explore, versus economic outcomes like earnings, education, whatnot. Okay, and this is a hard problem, and I've been thinking about this and trying to study this for a good 5 years now, I would say. And that's really the first paper that comes out of this agenda. And the hard thing is, so even forget about the data thing, right? So yeah, we all struggle with the data, and these are often very limited. But suppose you can have all the data in the world. There is still a fundamental problem here, that what you need is two orthogonal shocks. Okay, and this is extremely rare, and this is why it's so hard to study these policy interactions. Okay, so what we're going to show you today is we managed to find two shocks that are actually orthogonal to each other, and therefore we're going to be able to give the interaction effect a causal interpretation. Okay, so what do we contribute? We think that we contribute on a high kind of general science level. The primary thing is that we're going to give you these causal evidence on the policy interactions, on the shocks interactions. Okay, we're going to have prenatal health insult, and then we're going to have postnatal public policy intervention, and we're going to interact those two. Now, what we also think is important in our specific case is that we study actually shocks that, although random from the statistical perspective, are actually meaningful even contemporaneously for people and for societies. So our first shock is going to be exposure to seasonal influenza-like illnesses prenatally. Okay, so why do we care? Well, first of all, it's annual. So it's been with us forever. It's going to be with us for foreseeable future. It's hard to prevent, even with vaccination. The best flu vaccines are 50, 60% effective. And it affects a ton of people. Actually, the kind of best guesstimates are that depending on how severe the flu season is, about 5 to 20% of global population catch it, including many pregnant women. Okay. And here we're not talking about pandemic. So obviously this is also relevant, as I will talk a little bit more when I conclude to the recent COVID pandemic. But you shouldn't think about this as kind of pandemic treatment. Rather, we're going to actually have data on seasonal influenza-like illnesses. And then on the second shock, we're going to have this treatment, which is access to infant healthcare centers. So so we're going to study it in Norway, and there are these places in Norway. They were more important historically, but they still exist today, where women with infants 0 to 1 can just show up, and there is a nurse there, and they're going to get some guidance on how to care for the baby. The nurse is going to make a health checkup. And if needed, refer to a doctor, okay? And so first of all, that's a fairly popular health screening in both developed and developing countries. Secondly, many people around the world, right? So we're talking about developed countries here, but many people around the world actually don't have access to such checkups. And so this is potentially a promising kind of relatively cheap health intervention, okay? And on the final thing that we contribute is we're going to be able to use the amazing Norwegian data. So, we're less worried about things like measurement error. We're going to have the full population. So selection is not an issue. And the really, really cool thing that convinced me that we have something true here when it comes to the effects that we're estimating is we're also going to be able to do what I call a doubly robust estimator, which is basically we're going to stick into our estimation procedure mom fixed effects. So we're going to compare within families, so basically siblings that are affected differentially by these shocks, and all our results carry forward. So I think that's pretty strong evidence that that our results are believable. Okay, so what do we find? So first of all, we find that both inputs independently have statistically significant and economically meaningful consequences for long-run health and socioeconomic outcomes. So if you're prenatally exposed to seasonal influenza-like illness, it's bad for your earnings, it's bad for your education as an adult, it's bad for your health when it comes to both metabolic health index, as well as very basic things like height. So for instance, these children are shorter, okay? Independently, it is the case that if you have access to this healthcare center at the age between 0 and 1, this has positive effects on these outcomes, okay? So these kids are higher, they have fewer metabolic problems, they have more years of education, they have higher earnings. Now, critically, from what we want to study here is the fact that those children who have had access to these healthcare centers exhibit much smaller penalties from the prenatal exposure to influenza. So much so that we can wipe out up to 92% of the penalty in health outcomes and up to a little bit over half of the penalty in the human capital outcomes, such as education and earnings. Okay? So this tells you two things. First of all, that the two inputs are substitutes. Secondly, and I think critically from policy perspective, it tells you causally that you can use these subsequent positive inputs to offset some initial negative inputs that could happen randomly. It could be a flu outbreak, a COVID outbreak, a hurricane. But also, this potentially could generalize to more long-standing issues like, moms from lower socioeconomic status families might not be able to afford effective prenatal care or whatnot. Okay. And we're going to show you some information on also on mechanism. Some where we find some support for, and some that we can rule out. Right. So how are we gonna proceed with this? So the first sort of data piece that we need is we need to know about the prevalence of these infectious diseases. And it so happens that my co-authors, my fantastic co-authors, digitized month by municipality, Norwegian municipality data on infectious diseases for 1994 to 1952 in Norway, okay? And these basically give you counts of cases of things like flu, pneumonia, gastroenteritis, okay? And it's been an amazing effort they did. So just to give you an example, this is how these reports look like. So they actually went to the archive, photographed this, and then transcribed it. And so that took a huge kind of data collection effort. Okay? But this basically gives us variation in the prevalence of infectious diseases, in particular influenza-like illnesses. Okay? On the second treatment, we're going to use the rollout of child healthcare centers. So these centers were established as early as the 19 kind of 10s, 20s in big cities, but then it expanded, and basically between 1940s and 1960s, your non-Oslos, non-Bergens of Norway were getting it, and different places were getting the centers in different years. Okay, so that's going to give us variation in who was exposed to the center and who was not. And so that's going to be your kind of, for the statistical nerds in the audience, that's going to be your kind of standard rollout differences strategy. And we do all the new robustness checks that are recommended, and everything holds up nicely. On the outcomes, we're going to use Norwegian registry data. So we're going to focus on children born between 1942 and 1952. So for them, we're going to know where they were born, exactly, their demographics, as well as their education, lifetime earnings, things like take up of sickness leave or welfare benefits. So basically, for each kid, I know where and when they were born, and I can track them at individual level over the life cycle for the full population. Okay? We're going to also use a Connor data and National Health Screening Service data. So these are health surveys administered to adults in Norway at the age of 40. We're basically going to construct the index of metabolic health, including things like blood pressure, cholesterol, platelets count. I think, is there any kind of issues related to CVD diseases, cancers, things like that, okay? And so we're gonna make an index out of it, and that's gonna be one of our health outcomes. Our other health outcomes is gonna come in the form of height. And so we're going to know height at the age of 40 for the surveyed people, as well as we're going to know the height for all the males in Norway. So the Connor data, the age 40 data, has both males and females. For height, for males only, we're going to have the full population from Norwegian military records, and this is measured at age 18, 19, and draft is mandatory in Norway, so you cannot get out of it. So everyone is measured, basically. All males are measured. So in terms of inputs, we're gonna have two. How are we gonna treat the influenza? We're gonna code you basically as treated if there was what we call an outbreak of influenza-like illness in your place of birth at the time when you were a fetus. And we're gonna call it as top 5. So we have information at municipality by month, by year level, and we're gonna call an outbreak if your municipality is in top 5% in number of cases per capita over this 10-year period. We can do it within a year. We can do it, as far as top 10%, as little as top 1%, and our results are pretty stable. Once we start going beyond 10, 15% of highest per capita cases, our results are no longer significant, but that makes sense, right? This tells you that, basically the amount of virus that is circulating, or the severity of virus, is not strong enough to negatively affect people. And then for centers, we just know when and where they opened. Okay, and outcomes I already discussed. Okay, so how are we gonna proceed with that? With this in terms of statistics and econometrics. So basically what these kind of shocks do is they generate two differences designs that are then going to interact. Okay, so the first difference in differences is going to be the prenatal exposure to influenza. Okay, and so basically the way this is going to work, what we're going to compare here is there are going to be some municipalities where in some years there is going to be a lot of flu, and some municipalities in some other years where there isn't much flu. Okay, and so we're going to have municipality and time fixed effects, and basically we're going to compare individuals who are gestating in municipalities who which had an outbreak, compared to those that did not, before and after the outbreak. Okay, so that's your kind of standard diff and diff, and the assumption here is that basically flu outbreaks are not correlated with unobserved determinants of outcomes. For example, things like economic growth, right? So they kind of happen quasi-randomly, and we have pretty good evidence for that. For the healthcare centers, as I said, this is going to be the rollout style difference in differences. And so basically, I'm going to know when a center opened in your municipality. And so you're going to be treated if the center was open in a year when you were between ages 0 and 1. And the control group is not going to have a center, and then we're going to compare these municipalities over time. Okay, and so again, identifying assumption here is that center openings are not correlated with unobserved determinants of the outcomes. Here, one thing you might be worried is, something like healthcare preferences, right? So they go to places where people are more healthy because there is higher demand for that kind of center. Okay, so that would be problematic. Again, we do all these standard robustness checks as well as event studies, and all is nice and squeaky clean here. Now, when it comes to interaction, we're basically going to interact those two. So we're going to estimate this kind of monstrosity of an equation with, again, municipality and time fixed effects. And basically, let me tell you how to interpret this. Okay, so here we're going to have basically 3 objects of interest, actually 2 mostly. So we're going to have a dummy for this prenatal flu outbreak. We're going to have a dummy for whether you had a center between ages 0 and 1. And then we're going to have an interaction between those 2. Okay? So when you estimate this equation like that, the gamma 1 here, this is the measure of a flu outbreak for those individuals who are not exposed to healthcare center. Okay, so you can think about this as a kind of baseline seasonal influenza-like illness effect on long-run outcomes. Okay, gamma 2 is the center effect for those who are not exposed to flu prenatally. That's a nuisance parameter for us. But here we're interested primarily in this gamma 3, which is the interaction. Okay, it's the additional effect, either compensatory or reinforcing, of the center. Okay, so if gamma 3 and gamma 1 are of the opposite sign, this means that the 2 inputs are substitutes. If they're of the same sign, this means that they're complements. okay? And basically the sum of those two coefficients, which I call gamma 4 here, tells you, okay, to what extent the access to the postnatal intervention narrows or widens the initial inequality due to influenza-like illness exposure. Okay, so from policy perspective, what you're really interested in is comparing gamma 1 with the sum of gamma 1 and gamma 3. Okay. Okay, so how am I doing on time? Poorly. So trust me that we have parallel trends in flu outbreaks. Trust me that we have parallel trends in center openings. I can show you also the correlates maybe quickly. Basically, whether you have an outbreak is uncorrelated with either municipality level or individual level characteristics, F tests, kind of on the lower end jointly, but I think we're fine. And the same for healthcare centers. Again, nothing comes out statistically significant here. Now, the critical thing that I've been struggled with many of these interaction ideas is that the timing and location of the first shock has to be as good as randomly assigned with respect to the timing and location of the second shock. And so what it means, what the biggest worry here is for this specific application is, suppose you have these really bad flu outbreaks, seasonal flu outbreaks. And this organization that is building these centers decides, oh, it's really bad in these municipalities. Let's go and put the center there to help these people. That would violate the orthogonality assumption that we need, and basically we would have to toss the whole paper out. Okay. But it seems to be the case that that's not what they did. Okay. So what I'm showing you in this table is basically whether the healthcare center opening, that's the dependent variable, is correlated in any way with the prenatal flu prevalence in either average or these top 5% outbreaks. And you see that there is no statistically significant or economically meaningful correlation between those two. Okay? So that's basically supporting evidence for the orthogonality of the two shocks that we need to be able to causally interpret the interaction effect. All right, so let me show you some results. So all the tables are gonna be in the same kind of format here. And so I'm gonna show you the flu effect, the center effect, and then the interaction effect, okay? And so let's first focus on the years of education. So what column 1 tells you is that individuals that were gestating in places with high flu prevalence prenatally have fewer years of education. Okay? What column 2 tells you is that individuals who were born in places where the healthcare center was available to them between age 0 and age 1 have more years of education. Okay? In column 3, we put these two together. Now you see that the point estimate on prenatal flu exposure in column 3 is very similar to that in column 1. Similarly, the point estimate on prenatal healthcare center in column 3 is very similar to that in column 2. This is what we want, right? So if we put them in a horse race, if we include them together, if they are uncorrelated, the point estimates should not change much compared with univariable regressions. If they were correlated, which would violate our orthogonality assumption, as I mentioned before, you should see the movement of the coefficients when we include both of them. Okay, so that's another sanity check for our identifying assumption, basically for the interaction. okay? And then in column 4, you see two things. So first of all, the prenatal flu coefficient becomes much more negative. It more than doubles in size. What this tells you is, remember, this is the estimate for those who did not have center later on in their infancy, okay? So this is the kind of pure flu effect for those who don't get the subsequent treatment. And it makes sense if that is larger. Then we have the interaction effect. That's the opposite sign, right? This tells you that those who had flu, but also a center, have more years of education than those who just had the negative prenatal treatment, okay? And then when you sum A and C, you get the gamma 4 from the equation, and it's still statistically significant, but it's obviously much smaller than the prenatal flu estimate of 0.02. Okay, so this tells you two things. So first of all, as I said, that the two shocks are substitutes. Secondly, that you have a policy lever to reduce the consequences of the prenatal health shock. Okay, now you don't wipe it out, right? It's still statistically significant, and it's still negative, but it gets you, almost, the 0.076 is about a third of 0.206, right? So, you offset quite a lot of the prenatal penalty. And you can see the same thing for the earnings, right? Flu is bad, centers are good. The interaction is of the opposite sign of the flu effect, statistically significant. Here we actually managed to kill the statistical significance on the sum of those two, but nonetheless, the estimate is about a third of the kind of flu-only effect, if you will. Let's look at health outcomes now. So when it comes to health outcomes, again, same picture. Flu bad, centers good. The two inputs are substitutes. When it comes to metabolic health index, here the higher values are worse outcomes. So again, flu bad, centers good. The two inputs are substitutes. Okay, again, here we don't wipe the whole initial penalty out. Okay. When we look at some of the welfare outcomes at the age of 40, 50, we get somewhat less precisely estimated effects, but it's roughly the same story. So basically, prenatal flu bad, postnatal centers good. The two have opposite sign when we interact them. And here we're not statistically significant. Okay, these are consequential. Okay, so when it comes to quantities, because we have a lot of people, so maybe we're just picking up stars because we have large sample sizes. But if you look at the prenatal seasonal influenza outbreaks, especially for those who did not have the subsequent center treatment, they get about 2% lower years of education, 2% lower lifetime earnings. That's a lot. If you compute 2% of your life cycle income, there's a lot of money that's being left on the table. Okay, they're about 2% shorter. The metabolic health index, 28% of a standard deviation higher. More health issues compared to those who did not, who are not exposed to prenatal influenza. Okay, so these are kind of meaningful effects. When it comes to offsetting, as I said, it's 63% of penalty for education, 61% for earnings, 73% for welfare disability receipts, 92% offset for height, so pretty much we wipe it out quantitatively, and then 22% of a standard deviation for metabolic health index. So again, non-trivial reductions in these negative effects from the subsequent positive intervention. Let me skip this. We broadly, so there's about 4 or 5 other studies, including one great work by Valentina Duca, who is actually a member of Life Course Center, I think, on these interaction. No one does really health wealth except for the first paper, but they cannot trace it into any kind of meaningful long-run outcomes. But we're roughly in the ballpark of the folks that find substitutes. I think Valentina's work is kind of interesting because she actually finds complements rather than substitutes. This is just a bunch of robustness. You know, we do multiple hypothesis testing. The one thing I want to show you is the doubly robust estimator. So basically here in columns 1, 3, 5, 7, 9, and 11, you have our baseline results. And then in columns 2, 4, 6, 8, 10, and 12, we stick in mom fixed effects. And so these are within family comparisons, which you could imagine that it, you know, it wipes out a lot of potential additional confounders you can think about. And our results are pretty much the same. If anything, in few cases, the interaction effects are larger. And so I think that's kind of an important robustness. We do a ton of other robustness checks that are standard in the literature. Because we're short on time, I'm not gonna kind of bore you with that, but I'm happy to answer any questions afterwards about this. The last 3 to 5 minutes, I want to talk a little bit about mechanisms. So basically why prenatal influenza exposure or these illness exposure, these kind of infectious illnesses exposure are bad for the fetus is not necessarily because you know, the fetus gets the virus itself. It actually is very rare that the virus passes through placenta. At the same time, what the virus does is it puts pressure on mom's body, on mom's systems through inflammation, through increased energy consumption, and through reduced nutritional intake, okay? And so that's the primary mechanism why we think we have these negative effects. Now, one thing that the centers did is they offered nutritional advice. And Aline and others in her other paper actually showed that you know, this nutritional advice reduced diarrhea-related mortality in the treated children by 50%. So we think part of why we find this offsetting effect is the fact that, okay, they actually tell you how to properly take care of your baby nutritionally, and proper nutrition early on could have some of these offsetting effects, okay? The second thing that we think is happening is, as I said, you have these nurses, other trained medical professionals in the centers that they check up the baby, and if they think that there is something wrong with the baby, they're gonna give mom a referral to a doctor. Remember, these are 40s, 50s in Norway. It was still a relatively, you know, underprivileged, underdeveloped country at that point in time. So it wasn't like today that everyone has an access to GP, right? So this could have been important, okay? And so here, what we do to address this is we're gonna look at whether you had influenza outbreak in a year before, okay, and whether this predicts referrals to specialists. And just to you know, just to try to filter it out from general interest in health of the of the municipality. We're going to also show you some effects on other health outcomes like TB and rickets diagnosis. You know, if we think that it's improvements in general health, we should pick something up there. If we think that it's the seasonal influenza outbreak specific, we shouldn't pick up anything on TB and rickets because the two are unrelated. Okay, and this is exactly what we find. So first of all, nothing on TB, nothing on rickets, but it is the case that if you had an outbreak a year before of seasonal influenza, we see more referrals to specialists in the next year. Okay, so we think that, okay, these nurses look at these babies, there's clearly, you know, they're smaller, or, you know, there are other indicators of sort of unhealthy infancy, and they refer them to the doctors, and then the doctors sort of fix them up, and this could have these positive long-run consequences. You know, two other things that we can rule out are family size changes. So the idea here is that, okay, if you have shocks to child health, you know, maybe this affects your fertility, and then what we could be picking up is the effect of smaller or larger households. It seems that there is no effect on fertility. The other thing we were worried about, especially in this doubly robust estimator, is that perhaps there are sibling spillovers, right? So you have a sickly sibling. I have some work on this. And then parents kind of reallocate resources across siblings. And because of that, you know, our doubly robust estimators could be biased, or, you know, in a simple difference in differences, we can be picking up some of these effects. So what we do is basically, you know, we estimate these same equations, but for all these other siblings that we observe in the family, and we find flat zero effects. So there is no effects on siblings. And so, this gives us more confidence in the mom fixed effects alternative doubly robust strategy, but B, it also kind of rules it out, these spillovers, as a potential mechanism. Okay. So we're still going to have some time, so let me conclude. So to our best knowledge, this is the first evidence that a standardized, relatively cheap postnatal public health intervention can causally compensate for prenatal health shocks. You know, we show it in the context of what I think is an important health shock, because it affects up to 20% of people globally on an annual basis. Secondly, because it's relevant for the potential, you know, recent COVID pandemic, we already see in medical journals some papers suggesting that birth weight, gestational age, and other early kind of post-birth indicators of fetal health are negatively affected in mothers that contracted the virus in their pregnancy. And therefore, if you want to go policy-wise on this, you know, our results would suggest that, well, you better monitor those babies early on, and if there is a need for further medical intervention, you should probably intervene and help the babies on top of helping moms, you know, recovering from COVID. Thank you so much for your attention and for tuning in, and I'm happy to answer any other questions that you guys might have.
I see Marian has a question, so we can go with hands first, and then we can, if we don't get to the questions in the chat.
Okay, sounds good. Marianne, please.
Hi, Krzysztof. That was really interesting and fun. I really enjoyed it. I just wonder, in the family fixed effects, have you looked at if some of it could be to birth order, whether you control for that? Because we know family size and birth order are hard to distinguish at times, and they're going to be related, as you know, if you're later born, we know that the outcomes are going to be worse. At the same time, you're also exposed to more people in the household, more exposure, more impact. And the way to get around that, in a sense, is just including birth order, and then looking at completed families from a particular family size, as you know, you cannot put family fixed effects and birth order families, like, it's going to wipe that away. So it's just something that, just because I've worked on that, I always think about these things that comes across about looking at as an additional of the gazillion extensions and robustness checks you've done.
Yeah, that's a great question. I also worked on birth order. Funny enough, the paper I'm presenting on Friday at UNSW is another work on birth order. You're absolutely right. I think even bigger worry here is in these kind of differences design where you have a rollout. So, more and more places get it as time passes, you're more likely to treat later born. So that becomes even more important. So basically what we do is we control for birth order in all these regressions.
Thanks for the presentation. Super interesting stuff. I was wondering whether you received any pushback on the potential endogeneity of birth timing. Casey Buckles has got this paper that kids that are born in winter are more likely to born into underprivileged circumstances, and this could potentially correlate with the outbreaks and all that.
Yeah, so that's a great question. So we don't see much correlation with the outbreak and the socioeconomic status. I think we kind of get lucky here. We're talking about babies born in the 1940s in Norway. That was not a kind of sophisticated birth control society. I think a lot of the effects that Casey Buckles and others estimate come just from birth control. There was no birth control effective birth control in the 1940s. So in a sense, we get a little bit lucky here. We didn't get pushback on this, and we checked the fertility thing. And I can talk about it openly, where we get the pushback, which I think is the biggest weakness of the paper that I haven't mentioned is, the variation is effectively at municipality by year of birth level, meaning it's an intention to treat effect. I do not know which mother got the flu. I do not know which mother went to the center. Right? So if you're asking me what's the biggest weakness of this paper is the fact that we cannot estimate treatment on the treated.
Yep.
Obviously, this means that ITTs are lower bound, but if you're thinking about, doing stuff like cost-benefit analysis or anything like that, we're a little bit in a pickle. And on top of that, if you're thinking about speaking at all to Heckman, Cunha-Heckman, these kind of dynamics in human capital production, like we cannot even go there without knowing who is treated, who is not. So that's why we're pushing this as kind of policy interaction rather than human capital complementarities or whatnot.
Yeah.
Does that make sense?
I agree. Honestly, from a personal perspective, I also thought that the ITTs were a little bit large, just kind of thinking about the magnitude, especially given that you have the municipality treatment, not all the mothers will get infected. And then you're essentially saying that without the childcare centers or child health centers, 1 in 5 kids would get 1 less year of education as a result of this flu exposure, right? It feels a little bit
yeah. So on the effect sizes, what I can say is that. So I agree on flu. On the other hand, the interesting thing is that the only other paper that looks at seasonal influenza and economic outcomes is the work by Hannes Schwand, unpublished work by Hannes Schwand using Danish data, much more recent cohorts. He actually finds larger effects than we do. And so in a sense, like, that I agree with you. That was our initial reaction. But then I looked at his estimates and basically I was like, well, maybe we're not that crazy. On the center stuff, the lucky thing is that, again, we don't know exactly who went, but because it was such a poor country in the 1940s, from Aline's paper, about 75 to 90% of women actually used that. So at least on the second treatment, pretty much could go to one. Now, who got the flu? Well, we cannot even say that it was flu. That's why I was trying to be careful that it's influenza-like illness, because in 1940s, they had no clue. Like, there was no testing.
Gotcha. Thanks.
Really interesting paper. Thank you very much. So my first question is really, so you're pinning all of the sort of remediation to postnatal treatment and postnatal health intervention. So my question related to that is, how do you know that the introduction of the healthcare centres was not also related to some change in utero management of flu or illness that might modify the effects of flu exposure? So that's the first comment. The second thing that I was wondering about is, I'm not fully across all of the detail of how this works, but I think that some of the effects of flu are kind of specific to when they occur in the child's development. So if they occur in a particular trimester or a particular stage, then it will do something, whereas at other times in utero it might do nothing. And I just wondered whether you'd explored that at all as a way to, I guess, further enhance the robustness of your results. It's kind of a different placebo for you. So those are my comments, but overall I thought it was a really interesting paper.
Yeah, great question. Questions. Two answers. So the first one is both are, I'm not sure, going to be satisfactory. So these centers did not offer any kind of prenatal care and were explicitly not supposed to treat pregnant women. Now, I weren't there in the 1940s, so I'm unable to personally verify it, but we have not found any indication that they were used as kind of prenatal care suppliers. They even explicitly were only for children. So if mom was sick, like, mom would not receive a treatment there, even if she showed up with, a 6-month-old. So they were specifically targeted for these newborns to age 1. And all the anecdotal evidence that we can find on this suggests that they kind of obeyed by this restriction. So they would address the kind of broader spillover on the prenatal care. I think a more econometric point is, if you think that there is some corruption and something like that could be happening, then our estimates should be treated as lower bounds, basically. Right? If you think that prenatal care is good for these babies.
Yeah, it's not so much that it would be a lower bound; it's that it would be a different effect. If it say if you had, because you're talking about postnatal care,
Mm-hmm.
but if the introduction of the centre is correlated, even if the centre doesn't do it, if the introduction of the centre is correlated with a change in the way that doctors or hospitals treat flu or treat illness in pregnancy, then what you might actually be getting is that effect. That might be what mitigates the effect of flu on the child's outcomes rather than the postnatal care. So that's a different effect. It's not a lower bound on the same effect. It's a different effect.
Okay, this I haven't thought about. I don't know if we can test it. So basically you're saying municipalities that get the center have changed in their general supply of healthcare to pregnant women.
Yeah, that's the risk, because like the effects of flu on in utero development, it's kind of conditional. It comes with fever, I think. Again, I don't know all the nuts and bolts, so this is kind of another rabbit hole for you to go down, I suppose, in a way. But I think that it's not sort of just it is conditional on how you manage it, and I suspect it may also be conditional on when you get it in utero.
Yeah,
But
so on the
there's a
second,
bunch of other, you'll have to go to the medical literature to figure all this stuff out. But I think there's other opportunities there for you around the timing of the exposure. And I think that, you won't be able to show it definitively that they didn't change anything else in the way that they manage fever or flu-like illness in pregnant women. But if there's any, indirect evidence that you can look at there, or around other changes in the health, like in utero, or other changes in the healthcare system that occur at the same time, if you can document that, that would sort of help allay the concern, I suppose.
That's fair. I haven't thought about it as affecting the system, basically. Yeah, we can try to look at this. On the other thing, we did trimesters. We do find somewhat different results, where you would expect it. So basically, 1 and 2 are more affected. So this is when brain develops. This is also what Hannes finds. But our standard errors don't allow us to reject the effect for the 3rd trimester, which is also negative. So, we kind of swept it under the rug as we're underpowered, basically.
I think we are running out of the time. Thank Chris very much for this very interesting presentation and the audience of the Life Coach Center. So if you have any seminar suggestions, please reach to the seminar coordinators, me at CineUni and Rennie Lee from UQ. And a recording of this seminar will be made available in a few weeks. And the next Life Course Center seminar will be by Professor Matt Sanders next month. And thank you very much for attending, and see you next time.